This next case of acute endovascular intracranial mechanical thrombectomy uses retrievable stent technology. This case is of a 75-year-old female who presents to the emergency room at 7 o'clock in the morning with left hemiparesis and dysarthria. She was last seen normal at midnight. Her NIH stroke score is 11. She is not a TPA candidate. CT perfusion and a CT stroke study was obtained, where the aspect score was 9, showing a right MCA occlusion. She had an ischemic penumbra with increased time to peak in the right MCA territory and therefore was a candidate for mechanical thrombectomy. As you can see from the CT perfusion, there is significant territory at risk. And as you can see from the CT angiogram, there is a clear M1 occlusion in the MCA on the right side. Diagnostic catheter angiogram was obtained next, and specifically here we look at the access on the right side. You can see that this is somewhat of a complex aortic arch with significant curvature. As we navigate the right common carotid artery distal to the innominate artery, we try to get distal access with the wire and encounter a small hairpin turn around the level of C2. Once we obtain access and get our guiding catheters up, we obtain intracranial imaging. As you can see from the intracranial imaging, here's a clear MCA thrombus with an M1 cutoff on the right side. There is robust filling of the anterior temporal branch. At this point, we've identified the occlusion and bring up a triaxial system for a retrievable stent. Often with simple access, a biaxial system is sufficient, but given the complex anatomy in the aorta, we felt that more support would be needed and therefore brought up a triaxial system. Here you can see the intermediate catheter being brought in over a microwire and microcatheter. By having distal position of the microwire and microcatheter, we can bring the intermediate catheter well into the intracranial circulation, which gives us support to then bring the microwire and microcatheter across the lesion. Here we are roughly in the cavernous segment, bringing the wire now into the distal ICA and eventually into the middle cerebral artery. As we bring up the microcatheter, we also then bring up the intermediate catheter, which will be used both for support and potentially for suction. Here we can see the microwire crossing the middle cerebral artery, and that the microcatheter will be advanced over this wire once we have distal access with the wire. The wire will then be removed and the retrievable stent will be brought in. Here is a distal microcatheter run, which is important to assess thrombi or emboli in the distal middle cerebral artery territory. Once we know we're across the lesion, we bring in the retrievable stent. And rather than express this stent, we unsheath the stent, and that is a critical nuance. Here we can see the stent being deployed, specifically unsheathed across a lesion. Once the retrievable stent is unsheathed, we then bring the microcatheter well into the intermediate catheter and consider using suction thrombectomy with retrievable stent technology. You can see with the stent in place, we have flow that's reestablished. And now we retrieve the stent under aspiration. After this first attempt, we still had ticky zero flow, which is not uncommon, and now we'll try a second attempt. Here again we see the stent being unsheathed. We try to use a staccato type maneuver or short, small pulls not to lose the thrombus. And once we're in the guide catheter, we then pull aggressively. And here you can see complete flow restoration.